Okay, so let's do Chapter 58, Seizure Disorders. And just to forewarn you, it is 80 slides long, so this will be a longer voiceover. I am tending to do the more extensive PowerPoints in the voiceovers so that we can use class time in a more efficient way. So, seizures are transient, uncontrolled electrical discharge of neurons in the brain, interrupting normal function. Seizures resulting from metabolic disturbances are not considered epilepsy if seizures cease when underlying condition is corrected. So, metabolic disturbances associated with seizures include acidosis, electrolyte imbalances, hypoglycemia, hypoxemia, alcohol or barbiturate withdrawal, or dehydration and water intoxication. Extracranial disorders that can cause seizures are heart, lung, liver, or kidney diseases, systemic lupus, diabetes mellitus, hypertension, and septicemia. Epilepsy is a disease marked by a continuing predisposition to seizures with neurobiologic, cognitive, psychologic, and social consequences. In the United States, approximately 2.2 million people have active epilepsy, with 150,000 new cases diagnosed each year. It is the fourth most common neurologic disorder, with only migraine, stroke, and Alzheimer's disease occurring more frequently. Males are slightly more likely to develop epilepsy than females. People with Alzheimer's disease or who have had stroke are at a high risk for developing epilepsy. The risk is slightly increased in a child of a person who has epilepsy. However, most children would not inherit epilepsy from a parent. Seizure disorders may have many possible causes. Most causes vary by age. Common causes during the first 6 months of life are severe birth injury, congenital birth defects, infections, and inborn errors to metabolism. Common causes from ages 2 to 20 include birth injury, infection, trauma, and genetic factors. Common causes between 20 and 30 include structural lesions like trauma, brain tumors, and vascular disease. Common causes after 50 are stroke, metastatic brain tumors, and 1/3 of cases are idiopathic. So that means not attributable to any specific cause. Epilepsy or recurring seizures is caused by a group of abnormal neurons that seem to undergo spontaneous firing. This firing spreads by physiologic pathways to involve adjacent or distant areas of the brain. If this activity spreads to involve the whole brain, a generalized seizure occurs. The cause of this abnormal firing is not clear. Any stimulus that causes the neuron's cell membrane to depolarize induces tendency for spontaneous firing. Localization of the seizure focus is critical to the success of any anticipated surgical intervention. So scar tissue does develop over time from seizure activities. It's called gliosis. And the scar tissue is more, because of the scar tissue, there is more of a likelihood of these seizures to continue. It perpetuates the firing. Astrocytes release glutamate, which triggers synchronous firing of neurons. Therefore, drug therapy focused on suppressing the astrocyte signaling or decreasing glutamate release may be a mechanism by which to achieve seizure control. Other types of IgE are related to abnormalities in specific genes that control the flow of ions in and out of cells and regulate neuron signaling, or are involved with protein and carbohydrate metabolism. Many genetic mutations associated with epilepsy appear to be acquired rather than inherited mutations. In some forms of epilepsy, families do carry a predisposition to seizure disorders in the form of an inherently low threshold to seizure-producing stimuli, so the person may have such a response in the presence of trauma, disease, and high fever. Abnormal genes may influence the disorder in subtle ways. For example, a person with epilepsy may have an abnormally active version of a gene that increases resistance to drugs. This may help explain why anti-seizure drugs do not work for some people. This system is based on clinical manifestations of seizures. So let's look at the next slide for a figure. If a patient is diagnosed with a seizure disorder, it is very important to classify the seizure type correctly. The choice of treatment depends on the type of seizure. The preferred method of classifying seizure is presented in Table 58-5. Depending on the type, a seizure may occur in multiple phases. The prodromal phase, with sensations of behavior changings that precede a seizure. The oral phase, with the sensory warning that is similar each time a seizure occurs. The ictal phase, from first symptoms to the end of seizure activity. And the postictal phase, the recovery period after the seizure. The most common generalized seizure is the generalized tonic-clonic, formerly known as grand mal seizure. The tonic phase lasts for 10 to 20 seconds. The clonic phase lasts for another 30 to 40 seconds. Absence seizure is formally called petit mal seizure. Hyperventilation and flashing lights can precipitate absence seizures. The typical clinical manifestation of a simple absence seizure is a brief staring spell resembling quote-unquote daydreaming. This lasts about 10 seconds, so oftentimes it goes unnoticed. In complex absence seizures, the blank stare is accompanied by some form of movement, like blinking or chewing, even sometimes hand gestures, and can last up to 20 seconds. When untreated, seizures may occur up to 100 times a day. An EEG demonstrates a 3 cycles per second spike and wave pattern that is unique to this type of seizure. In atypical absence seizure, the staring spell is accompanied by other signs and symptoms such as eye blinking or jerking movements of the lips. The patient may be somewhat responsive during seizure activity. This type of seizure commonly lasts more than 10 seconds, as much as 30 seconds sometimes, with a gradual beginning and end. If the patient has cognitive impairment, seizure activity may be difficult to distinguish from usual behavior. Atypical absence seizures usually continues into adulthood. An EEG demonstrates atypical spike and wave patterns, usually greater or less than 3. Other generalized seizures are myoclonic, atonic, tonic, and clonic seizures. So for myoclonic, it's characterized by sudden excessive jerk or twitch of the body or extremities. The jerk represents a muscle contraction and may be forceful enough to hurl the person to the ground. These seizures last no more than a few seconds, but they may occur in clusters. Atonic seizures Akinetic seizure or drop attack, those are other names for this, involves either a tonic episode or paroxysmal loss of muscle tone and begins suddenly with the person falling to the ground. Seizures typically last less than 15 seconds. The person usually remains conscious and the normal activity can be resumed immediately. Persons with this type of seizure are at great risk of head injury and often have to wear protective helmets. Tonic seizures involve a sudden onset of increased tone in the extensor muscles, contributing to sudden stiff movements. Tonic seizures most often occur in sleep and affect both sides of the body. Patients will fall if they are standing when the seizure occurs. Tonic seizures usually last less than 20 seconds. Consciousness is usually preserved. Clonic seizures begin with loss of consciousness and sudden loss of muscle tone, followed by rhythmic limb jerking that may or may not be symmetric. Clonic seizures are relatively rare. Focal seizures are also called partial or partial focal seizures, are the other major class of seizures. So you can take a look at table 58-5. Focal seizures begin in one hemisphere of the brain in a specific region of the cortex, as indicated by the EEG. They produce sensory, motor, cognitive, or emotional manifestations based on the function of the involved area of the brain. For example, if the discharging focus is located in the medial aspect of the postcentral gyrus, the patient may experience paresthesia and tingling or numbness in the leg on the side opposite the focus. Focal seizures, continuation. I just forgot to click it, guys. So simple focus seizure, patients remain conscious and alert but experience unusual feelings or sensations that can take many forms. They may experience sudden and unexplainable feelings of joy, anger, sadness, or nausea. They also may hear, smell, taste, see, or feel things that are not real. Complex. Patients have loss of consciousness or an alteration in their awareness, producing a dreamlike experience. Their eyes are open and they make movements that may seem purposeful, but they cannot interact with observers. Some people display strange behavior, such as lip smacking or other repetitive, purposeless actions. During a seizure, some people may do things that can be dangerous or embarrassing, such as walking into traffic or removing their clothes. These patients need to take precautions before a seizure occurs. Patients may continue an activity started before the seizure, such as counting coins or choosing items from a grocery shelf, but after the seizure they do not remember the activity performed during the seizure. These seizures usually last between 30 seconds and 2 minutes. Patients may be tired or confused following the seizure and may not return to normal activity for hours. Focal seizures may be confined to one side of the brain and remain focal in nature, or they may spread to involve the entire brain, culminating in a generalized tonic-clonic seizure. Any tonic-clonic seizure that is preceded by an aura or warning is a focal seizure that generalizes secondarily. Many tonic-clonic seizures that appear to be generalized from the outset may actually be secondary generalized seizures. However, the preceding partial component may be so brief that is undetected by the patient or the observer, or even on the EEG. Unlike the primary generalized tonic-clonic seizure, the secondary generalized seizure may result in a transient residual neurologic deficit postictally. This is called Todd's paralysis or focal weakness, which resolves after varying lengths of time. Because they closely resemble epileptic seizures, psychogenic seizures may be misdiagnosed as epilepsy. Proper diagnosis usually requires video EEG monitoring to identify associated events. If the diagnosis of epilepsy is excluded, history of emotional or physical abuse or specific traumatic events often emerges. Some patients may have both psychogenic seizures and epilepsy. Care provided by a specialist in epilepsy is essential. It is defined as any seizure lasting longer than 5 minutes. The longer a seizure lasts, the less likely it is to stop without drug therapy. SE is a neurologic emergency that can occur with any type of seizure. The highest incidence occurs in children and older adults. During repeated seizures, the brain uses more energy than can be supplied. As neurons become exhausted and cease to function, permanent brain damage may result. Subclinical seizures are a form of status epilepticus in which a sedated patient seizes but without external signs because of sedative use. Convulsive status epilepticus is the most dangerous type because it can cause potentially fatal ventilation insufficiency, hypoxemia, cardiac dysrhythmias, hyperthermia, and systemic acidosis. Other forms of SE may be mistaken for altered mentation or movement disorders. Of deaths related to epilepsy, 40% are due to accidents during seizures, suicide, treatment-related death, death from underlying disease, and sudden unexplained or unexplained death in epilepsy. SUDEP is higher in males, persons taking multiple anti-seizure drugs, and patients with long-standing epilepsy who have poorly managed seizure activity. The direct cause of SUDEP is unknown, but thought to be related to respiratory dysfunction, cardiac dysrhythmias, or cerebral depression. Specific teaching about medication adherence and disease awareness is critical for at-risk persons. Once again, SUDEP stands for sudden, unexplained, or unexpected death in epilepsy. Perhaps the most common complication of seizure disorders is its effect on patients' lifestyle. Patients may develop ineffective coping methods because of psychosocial problems related to having a seizure disorder. In particular, an increased incidence of depression occurs in persons who have seizures that are difficult to control. Anti-seizure drugs and the continued need to manage a chronic disease also can contribute to depression. Although attitudes have improved in recent years, a diagnosis of epilepsy still carries a social stigma. Patients with epilepsy may experience discrimination in employment and educational opportunities. Transportation may be difficult because of legal sanctions against driving. Screen patients frequently for depression and encourage them to pursue available treatment options. A diagnosis of epilepsy or seizure disorder has many socioeconomic, physical, and psychological consequences for the patient. Thus, accurate diagnosis is crucial. The most useful diagnostic tool is an accurate, comprehensive description of seizures and the patient's health history. Look at Table 58-6. Ideally, an EEG should be done within 24 hours of suspected seizure. Abnormal findings help determine the type of seizure and help pinpoint the seizure focus. Only a small percentage of patients with seizure disorders have a normal EEG. Either repeated EEGs or continuous EEG monitoring may be needed to detect abnormalities. An EEG is not a definitive test because some patients without seizure disorders have abnormal patterns in their EEGs, while many patients with seizure disorders have normal EEG results between seizures. If abnormal discharges do not occur during 30 to 40 minutes of sampling during an EEG, the test may not indicate an abnormality. And I'm so sorry if you hear my dog breathing, but he's being a little ridiculous right now. The magnetoencephalography, that word, may be done in conjunction with the EEG. This test has greater sensitivity in detecting small magnetic fields generated by neuronal activity. A complete blood count, serum chemistries, studies of the liver and kidney function, and a urinalysis should be done to rule out metabolic disorders. A CT scan or MRI should be done in any new onset seizure to rule out a structural lesion. Cerebral angiography, single photon emission computed tomography, or SPECT, and an MRS, or magnetic resonance spectroscopy, and an MRA and PET may be used in selected clinical situations. The International League Against Epilepsy has developed specific diagnostic criteria for each type of seizure, including conditions that resolve over time. If a patient is diagnosed with a seizure disorder, the seizure type must be correctly identified. Once again, look at Tables 58-2 and Table 58-5 to determine appropriate treatment. Most seizures do not require professional emergency medical care because they are self-limiting and rarely cause bodily injury. However, if status epilepticus or significant bodily harm occurs, or if the event is first-time seizure, medical care should be sought immediately. Table 58-6 outlines the diagnostic studies and interprofessional care of seizure disorders, and Table 58-7 summarizes emergency care of patients with generalized tonic-clonic seizures, the seizure most likely to warrant professional emergency medical care. Cure is not possible. That's the most significant thing from this slide. The primary treatment for seizure disorders is anti-seizure drugs. Once again, look at Table 58-8. Because a cure is not possible, the goal of therapy is to prevent seizures with minimal toxic side effects from drug therapy. Drugs generally act by stabilizing nerve cell membranes and prevent spread of epileptic discharge. Drug therapy should begin with a single drug based on the patient's age and weight and type, frequency, and cause of seizure. Dosage should be increased until seizures are controlled or toxic side effects occur. If seizure control is not achieved with a single drug, dosage or timing of administration may be changed or a second drug may be added. About 1/3 of patients require a combination regimen for adequate control. Patients should discuss emerging treatments with their healthcare providers to provide the best control with the least amount of medication. The therapeutic range for each drug indicates the serum level above which most patients experience toxic side effects and below which most continue to have seizures. However, therapeutic drug ranges are only guides for therapy. If the patient's seizures are well controlled with a sub-therapeutic level, the drug dosage need not be increased. Likewise, if the drug level is above the therapeutic range and the patient has good seizure control without toxic side effects, the drug dosage does not need to be decreased. Serum drug levels are monitored if seizures continue to occur, seizure frequency increases, or drug adherence is questioned. Because they have very large therapeutic range, many newer drugs do not require drug level monitoring. Very important to teach your patients the importance of following the specific drug regimen and what to do if a dose is missed. This is another population where they tend to be non-compliant of their medication regimen. Primary drugs for seizures include Dilantin, Tegretol, Luminil, Depakote, and Mycilin or Primidone. The other generic names you probably know as well. Should know both names. Primary drugs that treat absence or myoclonic seizures include these that are listed. Then we have broad spectrum drugs that can be effective for multiple seizure types, which include this list of drugs. Lyrica is used as an additional treatment for focal seizures not successfully controlled with a single medication. Because Ativan and Valium are short-acting drugs, you need to follow their administration with long-acting drugs such as Dilantin or phenobarbital. Unnecessary combination therapy should be avoided whenever possible. Medication should be reviewed routinely, and the least effective medication discontinued by tapering. Anti-seizure medications must be tapered. Neurologic assessment for dose-related toxicity involves testing the eyes for nystagmus and evaluating hand and gait coordination, cognitive functioning, and general alertness. As a nurse, be knowledgeable about these side effects so patients can be informed and institute proper treatment. A common side effect of Dilantin is gingival hyperplasia, so excessive growth of gingival tissue, and hirsutism, especially in young adults. Medication non-adherence can be a problem, like I said before, with people with seizure disorders. Take measures to increase patient adherence to prescribed drug regimens. If healthcare providers are aware of non-adherence issues, they can work with the patient to find an acceptable drug regimen. Many older adults experience a first single seizure, and large percentage of them do not have another seizure. To be considered for anti-seizure drug therapy, older adults should have recurrent seizures, an obvious structural predisposition for seizures, or onset of epilepsy presenting as SE. Older adults are more responsive to anti-seizure drugs than younger adults, but they are also more likely to experience side effects at lower serum drug concentrations. In considering anti-seizure drug therapy for older adults, you should recall the relationship between drug action and normal changes that occur with aging. For example, Dilantin is widely used to treat seizure disorders. However, because the liver metabolizes Dilantin, its use should be avoided in older patients with compromised liver function. Age-related changes in liver enzymes decrease the liver's ability to metabolize drugs. You guys can take a look at, this is unrelated to this PowerPoint, but the Beers list for high-risk medications for elderly folks. You can find that on the internet. It'll give you a list of drugs that we should never give the elderly folks because of reasons just like this. Because phenobarbital, carbamazepine, and primidone have potential effects on cognitive function, their use may also be less desirable for older results. Several newer anti-seizure drugs offer greater treatment benefit to older adults. Compared with older drugs, gabapentin, lamotrigine, oxcarbazepine, and Keppra may be safer, have fewer side effects and on cognitive function, and have fewer interactions with other drugs. Despite availability of newer drugs with fewer side effects, no solution has been found for medically refractory epilepsy or unresponsive to drug therapy epilepsy. If a patient's seizures fail to respond to the first two prescribed anti-seizure medications, the likelihood of achieving a seizure-free life with further medication changes is only about 5 to 10%. A substantial number of patients with uncontrolled epilepsy are candidates for surgical therapy to remove the epileptic focus or prevent spread of epileptic activity in the brain. The classic surgical intervention has been an anterior temporal lobe resection. However, the current goal of neurosurgery is a careful resection of a precisely localized area with a lobe of the brain. Approximately 7 to 80% of patients become seizure-free after surgery, and 10 to 20% experience a marked reduction in seizure activity. Not all types of epilepsy can benefit from surgery. An extensive pre-operative evaluation is important, including continuous EEG monitoring and other specific tests to ensure precise localization of the focal point. Surgical candidates must meet 3 requirements. First, have a confirmed diagnosis of epilepsy. 2, an adequate trial of drug therapy without satisfactory results. And 3, a defined electroclinical syndrome. So what type of seizure disorder? Has to be clearly defined. Vagal nerve stimulation is a form of neuromodulation, is used as an adjunct to drugs when accessible focal point cannot be identified for surgical removal. The exact mechanism of action is unknown, but it is thought to interrupt the synchronization of epileptic brainwave activity and stop excessive discharge of neurons. In vagal nerve stimulation, a surgically implanted electrode in the neck is programmed to deliver the electrical impulse to the vagus nerve, usually on the left side. The patient can activate it with a magnet when he or she senses a seizure is imminent. Vagal nerve stimulation can cause adverse effects such as coughing, hoarseness, difficulty breathing, and tingling in the neck. Battery life is approximately 5 to 10 years, and surgical replacement would be required. Benefits of this therapy can be seen within 24 months after implantation. A ketogenic diet is a special high-fat, low-carbohydrate diet that has been used to control seizures in some people with epilepsy. When a person is on this diet, ketones are produced and passed into the brain and replace glucose as energy. Meals must be carefully planned because the amount of protein and carbohydrates in the diet must be restricted. Patients on this diet who use anticoagulants need close monitoring for bleeding. Although healthcare professionals are more likely to recommend the diet for children than adults, the diet can work equally well in both age groups. However, long-term effects of the diet are not clear. Biofeedback to control seizures is aimed at teaching the patient to maintain a certain brainwave frequency that is refractory to seizure activity. Further trials are needed to assess the effectiveness of biofeedback for seizure control. Subjective and objective data that should be obtained from a patient with a seizure disorder are presented in Table 58-9. Data related to specific seizure episode can be obtained from a witness. Medications, adherence to anti-seizure medication regimen, barbiturate or alcohol withdrawal, use and overdose of cocaine, amphetamines, lidocaine, theophylline, penicillin, lithium, phenothiazines, tricyclic antidepressants, and benzodiazepines. You're also going to go over their history, ask if they have any headaches, aura, mood, or behavioral changes before the seizure, anxiety, depression, loss of self-esteem, social isolation, decreased sex drive, erectile dysfunction. The precipitating factors: metabolic acidosis or alkalosis, hypercalcemia, hypoglycemia, dehydration, or water intoxication. Did they bite their tongue? Do they have any soft tissue damage, cyanosis, abnormal respiratory rate, apnea, absent or abnormal breath sounds, or airway occlusion? We also want to check for hypertension, tachy or Brady. Are they tachy or Brady? Bowel, urinary incontinence, excessive saliva or salivation, weakness, paralysis, ataxia, abnormal CT, MRI, or EEG. Then for a nursing assessment for the generalized seizures, the tonic and clonic symptoms include, you'll see there on the slide, and the absent seizures include the other set of symptoms. Then we have simple, the focal seizures, the simple seizures, and those are their characteristics. I would recommend making some flashcards or something so that you can differentiate between the different types. Then you'll have complex, and these are their presenting symptoms. Then for planning, the overall goals are that the patient with seizures will, number 1, be free from injury during a seizure. Number 2, have optimal mental and physical functioning while taking anti-seizure drugs. And 3, have satisfactory psychosocial functioning. Improved approaches to perinatal labor and delivery care have reduced fetal trauma and hypoxia, and thereby have reduced brain damage leading to seizure disorders. Help the patient to handle stress constructively. When a seizure occurs, the nurse should carefully observe and record details of the event because the diagnosis and subsequent treatment often rest solely on the seizure description. Note all aspects of the seizure: what events preceded the seizure, when did the seizure occur, how long did each phase, so the oral, the ictal, and the postictal last, what occurred during each phase. Both subjective data, usually the only type of data in the oral phase, and objective data are important. Note the exact onset of the seizure, so which body part was affected first and how, the course and the nature of the seizure activity, loss of consciousness, tongue biting, stiffening, jerking, total lack of muscle tone, the body parts involved in their sequence in involvement, and the presence of autonomic signs such as dilated pupils, excessive salivation, altered breathing, cyanosis, flushing, diaphoresis, or incontinence. Assessment of the postictal period should include a detailed description of the level of consciousness, vital signs, pupil size and position of the eyes, memory loss, muscle soreness, speech disorders. Are you seeing any aphasia? Weakness or paralysis, sleep period, and the duration of each sign or symptom. After the seizure, the patient may require repositioning to open and maintain airway, suctioning, and oxygen. A seizure can be frightening for the patient and others who witnessed it. Assess their level of understanding and provide information about how and why the event occurred. This is an excellent opportunity for you to dispel many common misconceptions about seizures. After observation and treatment of the seizure, implement patient and caregiver teaching and psychosocial intervention. Do you know what to tell someone if they are interested in buying a seizure response dog? First, they need to contact Canine Assistance, one of the largest nonprofits that provide seizure response dogs. They actually specialize in seizure dogs. Understand the process. Although the cost to train a seizure response dog is up to $20,000, they provide the dogs free of charge to recipients. The cost is covered by private donations to canine assistance. However, your patient will need to fill out an application and get on a waiting list. Complete the application. The application and medical form needed is located on the Canine Assistance website. Mail to the address provided on the form. Consider getting on the wait list with a few organizations. If your patient is anxious about getting a dog, you can suggest they fill out applications for a few organizations. This will give you a better chance of finding a dog sooner. Paws with Cause offers a program, and you can check the American Dog Trainers Network list for programs in your state. Be patient while waiting for a dog. The wait list for seizure dogs can be a couple of years. If a dose is missed, usually the dose should be made up if the omission is remembered within 24 hours. Guidelines for teaching are shown in Table 58-10. Remind family caregivers and significant others that it is not necessary to call an ambulance or send a person to the hospital after a single seizure unless the seizure is prolonged, another seizure immediately follows, or extensive injury has occurred. Patients with seizure disorder also experience concerns or fears related to recurrent seizures, incontinence, and loss of control. For issues relating to job discrimination, refer patients to the State Human Rights Commission or the State Department of Vocational Rehabilitation. Assist the patient in finding appropriate resources like a local chapter of the Epilepsy Foundation. Usually you could find those at www.epilepsy.com. The Department of Veterans Affairs for Veterans, Community Mental Health Center for intensive psychological counseling, social workers and welfare agencies for those with financial problems and living arrangement needs, vocational rehab services for job placement when seizures are not well controlled. Driving laws related to patients who have had a seizure vary from state to state. For example, some states require a 3-month seizure-free period before issuing or reissuing a driver's license, whereas others require up to a year. The EF provides current information on driving laws for each state. Inform the patient that medical alert bracelets, necklaces, and ID cards are available through EF, that's the Epilepsy Foundation. Local pharmacies or companies specializing in identification devices. However, the use of these medical identification tags is optional. Some patients have found them beneficial, but others have found them to be more a burden than help because these individuals prefer not to be identified as having a seizure disorder. Encourage the patient to learn more about epilepsy through self-education. Expected outcomes are that the patient will be seizure-free, experience breathing pattern adequate to meet oxygen needs, experience no seizure-related injury, express acceptance of seizure disorder by admitting presence of epilepsy and adhering to recommended treatment regimen. Additional expected outcomes are presented in the nursing care plan on 58-2, available in your book or on the website.